There we go. Perfect. I'll let you go on now.
Good. Great. Thank you very much. Welcome, everyone. We're going to be talking about SBIRT and school-based health centers today. And just want to thank some previous folks there who we've, well, we're moving along here. Well, that'll be the first slide when we get to it. Just want to thank, as a part of this project there, we talk with other states who are basically have done SBIRT and school-based health centers. We talked with North Carolina, we talked with Colorado, we talked with Massachusetts, and they were all very forthcoming with talking about their experiences and sort of, you know, what are some of the structures you have to put in there, and also what are some of the barriers that you're probably going to face. We also talked with Dr. Sharon Levy and Dr. John Knight, who gave us a tremendous amount of information. They're from Boston Children's Hospital over, obviously, in Boston. And also, a lot of the material you're going to see later on there, we sort of borrowed from School of Public Health at Boston University. They have the BNI Art Institute there, so we borrowed some of their materials there. They have really good materials there, so we just wanted to sort of inform you, the folks there. So we didn't necessarily reinvent the wheel there, and I think that's one of the nice things about SBIRT in general, but especially with school-based health centers is, you know, everyone was very open in talking with us and sharing information there, and, you know, more or less whatever they had, they were willing to share with us there. So we found that, you know, very helpful. You know, the other thing, too, is obviously implementing SBIRT in school-based health centers is basically, you know, as we believe, pretty much a win-win for everybody. It's positive for the youth there because hopefully we're preventing and or delaying the beginning of alcohol and substance use and delaying the problems that are associated with it. It's beneficial for the school, obviously, because you'll see some of the information there later on how the negative effects of alcohol and substance use it has on the school environment, and also for the school-based health center there. We'll look at some of the other data there later on there. We'll sort of give you a structured way of basically addressing the alcohol and substance use needs that are identified in the system there. Before I turn this over, I think just sort of SBIRT in general, I think is sort of an exciting you know, project in and of itself, because it basically should integrate healthcare with the addictions field, where previously they've sort of been sort of two separate silos there, where this is hopefully going to bring addictions into healthcare and looking at alcohol and substance use as a part of regular healthcare there. So I think this is SBIRT in general is you know, tremendous evidence-based practice, and with our experience in school-based health centers, you know, we're all pretty enthused about our efforts and the work we've been working with the school-based health centers there. So I'm going to be handing this off. We're going to be, Shirley DiStefano is going to be going after Dr. Brett Harris. She's going next here, and she's going to be walking through some of the initial data there and also a survey that she did. What we would like to try to do is after, we're going to have, you know, going back and forth. So after Brett gets done, we'll have a little break there for questions. We'll handle those, and when Shirley gets done, we'll have another break, and I'll sort of be batting cleanup here and go in the end there. So that's sort of what we have plan-wise for questions there. And without further ado, I'll hand this over to Brett.
Okay. Brett, just a second, sorry. I got a couple of emails from people who don't know what SBIRT stands for. Could you give that information to them? Thanks.
Yes, not a problem. I just wanted to begin by saying that I'm going to be presenting on the background of adolescent substance use, and then I'm going to be talking about why we think SBIRT, which I'll define in a minute, is a good fit in school-based health centers. And then based on the experience that we have, I'm going to turn it, we'll break for questions, and I'm going to turn it over to my colleague Shirley, who's going to discuss the protocol that we use in our projects in school-based health centers. So SBIRT stands for Screening, Brief Intervention, and Referral to Treatment, and it's really just it's an integration of substance use services into public health settings, and we will get more into detail what SBIRT is later in the presentation. So pretty much to define it, it stands for Screening, Brief Intervention, and Referral to Treatment. So in New York State, adolescents are using substances. Alcohol use, almost 40% current users, meaning in the past 30 days. Drinking alcohol for the first time before the age of 13, 19%. 22% reported binge drinking, 20% reported current marijuana use, 7.6% tried marijuana for the first time before age 13, and about 10% reported using inhalants. So the negative consequences of substance use. So one thing, it increases risky behaviors. So as you can see here, there are many teens engaging in risky sex, and as a result, large numbers of unintended pregnancies. Also, adolescents who are substance users are more likely to be sexually active, engage in risky sexual behavior, as I said, become pregnant, and contract STDs, sexually transmitted diseases. So as you can see here, of people that reported, you can see risky sexual behavior during and last sexual intercourse among New York State adolescents. Over 20% had alcohol or used drugs. Almost 40% had not used a condom. Over 80% did not use birth control pills, and over 10% did not use any method of contraception. Substance use also contributes to the top 3 leading causes of death among adolescents: motor vehicle accidents, homicides, and suicides. So why we say that SBIRT is a very good fit for adolescents is because substance use, even at its first time, increases the risk of unintentional injury or death. It doesn't matter how often, if they're dependent users, so it's even the first time. 68% of emergency department visits involved the use of alcohol, drugs, or misuse of prescription drugs in 2008. And over 30%, 15 to 20-year-olds, were involved in fatal crashes in 2008 as a result of drinking. Underage drinking is also, it's associated with homicides, non-fatal violent crimes such as assault, robbery, and rape, and property crimes, so car theft, burglary, larceny. Substance use results in fights. So in general, almost 30% of New York State high school students have gotten into a physical fight in the past 12 months. But among current drinkers, that number increased to 43.6%. And among binge drinkers, 53.5%, and current marijuana users, 53.6%. So you can see of those people, those adolescents using substances, they're more likely to get into fights. There are also negative consequences for school outcomes. So adolescent substance users are twice as likely to have poor grades and drop out of high school. They're more likely, as I said, to get into fights, and that at school specifically. It's also associated with school misconduct and lack of effort and interest. So there are also health concerns, a lot of them more longer-term health concerns as a result of substance use, so liver disease, stroke, and cancer, headaches, eczema, irritable bowel syndrome, and then, as I said before, HIV and STDs, and alcohol poisoning or overdose. So as we talked about binge drinking and the type of situations that adolescents get into, there is that chance of that acute issue occurring. As I talked about all of these negative consequences, many of them are the same for binge drinking. Also increase in smoking cigarettes or cigars, being a victim of dating violence, attempting suicide, and of course using illicit drugs. But just briefly, because we've mentioned binge drinking, what is binge drinking? Well, we at OASAS follow the guidelines that are given by NIAAA, National Institute on Alcohol Abuse and Alcoholism, as to binge drinking among younger people. So we take the threshold changes based on age, and as you can see, for younger students, 3 or more drinks would be binge drinking, and then it's broken down by girls and boys and by age. So as they get older, the threshold becomes larger. So there are also mental health issues that are associated with substance use. So here we focus on depression. So in general, 26.9% of adolescents reported symptoms of depression in the last 12 months in New York State, compared to among current drinkers, 40% reporting depression, 43.4% of binge drinkers reporting depression, and among current marijuana users, 37.7% reporting depression. And then 18.6% of binge drinkers attempted suicide during the past 12 months. So there are also, longer-term effects. So early initiation of alcohol increases the likelihood of future dependence. So going back to that early slide that said the number of students that had started drinking before the age of 13, that was 19%. You could see that that does create an issue, so we need to address this problem early before the drinking gets out of hand and to prevent that future dependence. So cognitive brain functioning in the brain can also be permanently impaired even if the adolescent stops using. Underage drinking is costly, and everywhere, but here we have some numbers specifically for New York State, and many different categories. So addressing this issue can help our state as well as all the states represented on this call to reduce those costs. So what is SBIRT? So I did define that: screening, brief intervention, and referral to treatment. So the goal of SBIRT is to identify at-risk substance users in non-substance abuse treatment settings. So it's really a public health intervention, putting early intervention for substance use in public health settings. So specifically here we're focusing on school-based health centers and having individuals that work at the school-based health center being trained to provide SBIRT. So screening becoming part of a normal process among all the other screening questions, using a standardized tool, which we're going to get into, to identify individuals along a spectrum of use, not just identifying the dependent users, but along a spectrum from non-use to dependence, and then providing, when appropriate, brief interventions on site right then and there at their appointment, and using motivational interviewing to address the issues that are involved with the student's use, and then providing referrals to treatment when necessary for the more dependent users. And of course, for students that don't have issues, providing encouragement. So SBIRT addresses student needs in a number of ways, and I'll get into them more in detail as we go along, but it reduces alcohol and marijuana use, prevents initiation of substance use. Prevention saves your organization money, offers convenience and confidentiality for the student, and it's a good fit for adolescents. And adolescents have reported satisfaction with SBIRT. And very important, it is recommended by the American Academy of Pediatrics to be done routinely and annually in primary care visits. So research has shown that SBIRT increases students, and especially adolescents, readiness to change their substance use behavior, specifically self-efficacy for making those changes, so the confidence they have in their ability to make a change. It decreases their intentions to use, and it decreases the perceived prevalence of peer substance use. So as we know, adolescents seem to think that their friends and their peers are using substances at higher rates than they really are. So in the brief intervention, the counselor does try to explain to the student what normal levels of use are, and this research has shown that that the adolescent does get a better understanding as a result of SBIRT of how much their peers are really using. It also prevents initiation and reduces use. So some studies out of Boston University, Boston Children's Hospital, I should say, showed that SBIRT lowered past 90-day alcohol use and other drug use. There was a control group, so that usual care group represents the control group. And it showed decreased marijuana after 3 months. This was a different study. And then it also reduced adolescent drinking onset. So we know that there are a lot of adolescents that haven't started using, but SBIRT can be effective at preventing initiation, and also that it reduced the risk of drinking and driving. So SBIRT is ranked among the top 5 most beneficial and cost-effective preventative services by the U.S. Preventative Services Task Force. So we're talking about integrating this in with regular screenings that are done, when you go into a doctor's office. So, however, SBIRT has been ranked higher than screening for high blood pressure, which you probably get every time you go in for your annual, and also for high cholesterol, breast, colon, or cervical cancer, and for osteoporosis. And the research shows that $4.3 are saved for every dollar spent on substance use early intervention. Now, school-based health centers are a unique setting because they are located in the school, which is great because students spend most of their days there. And but however, it provides, that's the convenience, but it also provides the confidentiality of a primary care health setting. It's covered by HIPAA privacy, and so students, and then research has shown that students are willing to discuss their substance use with a knowledgeable healthcare provider, and then they report not feeling judged. So they're, with the convenience, being able to get to the to get their services without having a parent having to drive them, and also the confidentiality and the knowledgeable healthcare provider make this a good setting to conduct SBIRT. Now, we all know that adolescents are, autonomous. They're trying to get autonomy. They're at that point in their lives, and they're ambivalent about changing their substance use and don't always, listen or take authority, information from authorities very well. So SBIRT provides a self-guided structure, not forcing students to admit having a problem. So they pretty much, as Shirley will talk about, the motivational interviewing aspect of the brief intervention is pretty much guided by the adolescent with the assistance of the counselor. So it allows them to develop action-oriented goals while avoiding confrontation. The adolescents have reported satisfaction with SBIRT. They rated the provider advice as excellent or very good. They were satisfied with the services, and they were very likely to follow through with the advice. And as I said, this it is recommended by the American Academy of Pediatrics. This here is the statement. The American Academy of Pediatrics and the American Medical Association recommend that pediatricians and other healthcare providers who work with children and adolescents conduct routine substance use screening and brief interventions using motivational interviewing techniques, and that they become familiar with the network of treatment providers should an outside referral be necessary. Okay, so we're going to take a minute or so to take a break for questions before I turn it over to Shirley.
Hi, I don't have any questions or comments yet. Thanks.
It must be so clear that there's no questions resolving at all. Very nice job, Brett.
All right, so I'm just going to turn it over to Shirley DiStefano.
Hi, welcome to today's presentation, and I hope you can hear me because I'm sitting across from everybody right now. So, Chris, if there's any problems with my projection, please let me know. I'll try to project.
Yeah, if you could get closer to the mic or your phone headset or whatever you're using, I think it would be helpful.
Okay, I think I'm standing up. What I'm going to be talking about today are the basic components of the protocol that we recommend and we actually train all of our school-based health centers to use. And we use the craft, and in talking about this in the protocol, I want to be clear that there really is no one single way, for instance, of doing this. We tend to try to spend time within the school-based health center to get an idea of how their clinics flow, their staffing patterns, and their ability to be able to integrate this particular screening and intervention process into their everyday clinical protocol. And as I said, it takes extra time to understand that and to get everyone to try to figure out what is the best way. And as I said, I don't know one best way. It's usually customized per site. So let's talk about the craft screening tool right now. And I want to say this is a screening tool and not to be confused with a diagnostic or assessment instrument. The screening tool provides a guidance for you to look at and to be able to judge risk factors and the ability or the use and the need for having an assessment that will come up. But what do we look at in a screening tool for adolescents or any screening tool? And what we know is that, especially for our adolescent patients, we need one that is accurate, developmentally appropriate, and has validity. And the craft screening tool has all of those. Plus, it's very quick and easy to administer by the individual at your program, or it can be self-administered, or it can be in something which is catching on quite quickly in a electronic medium, and is also very compatible with most electronic medical records. So let's look at the craft itself. We do a Part A and a Part B. And the Part A has the 3 pre-screening questions, and the Part B has the traditionally what we know as the craft, the CRAFT, which is a mnemonic for the parts that I will talk to. A positive craft means that the student should be assessed for further alcohol and drug dependence. Okay, this is an actual paper craft screening questions. And again, depending on how it's set up in your setting, it could be that you might want to do the first 3 and then decide about the next part, or you might set it up just to know what the first 3 are. And if you're doing it in person, it's always nice to set up a little report before you start asking the questions. So I'm going to go through these quickly, and it says please answer all questions honestly, and they will be confidential. It's underlined. Brett talked about the confidentiality, and it's very important to understand that within the school-based health center, there are certain types of confidentiality that is inherent in the process of who they are. However, within your overall programmatic aspects, you may need to discuss that yourselves. So for the first 3 questions, you're saying, during the past month, did you, and this is drink any alcohol, more than a few sips, and that's a yes or no, and you check it. Did you smoke any marijuana or hashish or whatever you might be having students talk to you about? Use the vernacular if you can, whatever they're calling it. Number 3, did you use anything else to get high? And that could be both illegal drugs, over-the-counter, and things that you can sniff or huff. Most recently I saw that thing about using that lip balm on eyelids, and students were getting really weirded out. So I think it's important to ask if that's the behavior that they're doing, that you ask what other things are they doing. So if every student or any student answers no to all of these, you still have to get into Part B, which is the CRAFT. And the reason for that is you would ask the next question, which is, have you ever ridden in a car driven by someone, including yourself, who was high or had use of alcohol or drugs? Now, why are we doing that? We're doing that because we are assessing risk factors, and whether or not that adolescent has said no to all of those above, but they've gotten into a car with someone they know had been drinking, that's a risk factor. And it's something that you would address, and we'll talk about that in a few minutes. However, if they have asked and answered yes to any one of those first 3, you will then begin the craft automatically and answer all of them as we say in Part B, but it is the actual CRAFT that we will ask. So again, I've already started on Part B, and the reason that we're looking at Part B is because when you're asking the questions, the first question on the craft says, have you ridden in the car? In the car, getting a license, having a car at your disposal indicates a certain element of responsibility, both for the vehicle and for the use or misuse of the vehicle while you're being high. Some people have said, well, you know, we're in the city and we don't have a lot of car use. Well, it's still important to ask the question because you never know when somebody may have the opportunity when they're visiting other people, when people come with cars to visit them. Do you ever use alcohol or drugs to relax? You know, feel better about yourself or to fit in. And we already know that in adolescence one of the greatest pressures is from your peers, and there is that need to try to fit in. And the component here is, are they relaxing? So in other words, it isn't just for pleasure anymore. They're actually looking at some of the coping mechanisms that they may have to ask themselves about. Do you ever use alcohol or drugs while you are by yourself or alone? It's surprising, but a lot of kids who do feel isolated and alone may use alcohol as a coping mechanism to help feel better about themselves. If they are experiencing depression, there's that initial feeling of elation with the use of alcohol or drugs. But the key thing here is that they're either isolation or they are feeling some form of social isolation. Next question is, do you ever forget things that you did while using alcohol or drugs? Here again, we're looking at this and we're looking for it in the sense of, is there a problem of impairment here? And forget means that there's something that happened during the time, and we're not necessarily saying that this is a blackout that they're experiencing, but there might be lapses in the memories of events during the time which they used alcohol or drugs. Next question is, do your family or friends ever tell you that you should cut down on your drinking or drug use? Well, number one, if they're recognizing it and they're recognizing the effects, then it's pretty obvious, but the use has gotten to another level. They usually try to hide it, they try to cover it up. Now it's being known, and it's something that has increased the level. So have you ever, next question, so have you ever gotten into trouble while you were using alcohol and drugs? Lots of times kids don't want to answer this question because it's not so much they care about whether they're getting into trouble, but it might be the association with other people, their peers, who they might not want to rat on, which is also a part of peer pressure. So in asking the questions and having them fill it out, it's always good to have that type of information. But any time an answer is yes, it counts as a 1 point. And a no, of course, is 0. So in this sense, you're actually scoring it, and you'll be tallying it, and I'll be telling you about that in a minute. As I said, the scoring for this, and this we use directly from our major source, which is again out of Boston. A low risk is 0. Now you're wondering, why is this a low risk? Because it's a potential for use, and if there is absolutely no use, complete abstinence, and no indication of a risk behavior, then pretty much what you need to be able to do is to provide positive feedback and lots of encouragement and praise for those behaviors that that adolescent has been able to use and integrate into their lives because they're being successful. And again, following the whole procedure of MI and being open to giving this kind of feedback and asking to give this feedback, that's what you're looking for. A score of 1 is moderate risk. And moderate risk means that we're looking at, and it depends somewhat on how they're answering the questions, as I just indicated, that you know, it indicates certain things about what their behavior is doing, but you provide brief advice to them. You're telling them that maybe within their age group, as Brett showed you, that binge drinking at that age can cause certain problems. They may not even know what a standard drink is. They may not even understand that binge drinking can cause alcohol poisoning, and by standards, that's 14 standard drinks would probably put an adolescent right over the edge and beyond the 0.08 in most states it has to be. Score of 2 or more with no signs of acute danger and is still high risk. Acute signs of danger comes from an algorithm that we use when we do the training, and in the algorithm we talk about certain factors that would indicate that, for instance, has the adolescent gone to an emergency department for an alcohol or drug overdose? That's one of those high risk factors. has an adolescent been riding in the car or driving the car while intoxicated or under the influence, then we would say, yes, that's a very high risk. And you would provide the brief intervention, and I'll be talking about that in a moment, and we use the BNI as referenced. A score of 5 or more, that gets you right over the top, and that is whether or not there's acute signs and high risk. But here again, what we're doing is providing the brief intervention with the goal of acceptance to a referral treatment. And we hear all the time from our providers that it's really difficult sometimes to get the adolescent while they're in the school-based health center to actually start thinking about and moving towards getting treatment. And also what they would be getting there is a full psychosocial assessment and a diagnosis of whether or not they have a substance use disorder. Again, I'm throwing this in to bolster the fact that we really believe that the CRAFT is a good predictive tool that will help you. It gives you that measurement that often many people will say, oh, well, I know because I can use my clinical intuition. I can tell. I hear this all the time. Well, hey, we're giving you scores. We're giving you an indicator that has an actual measure and something that you can write in on your electronic medical records for billing, which Gary will talk about later. And as you can see on the right-hand side, you have a diagnosis of dependence from 0 up to 100, and across it you have the scores. So you see that as the predictive value increases with the score, and it gives you, again, that reliable measure to move forward with, and gives you an actual place to be able to bill for. Next, the brief negotiated interview, and this is going to be pretty quick, but when we're doing the training, we usually spend a great deal of time on this using the actual outlines, and they have a handout that could be useful for this. And we pretty much go through all of it, but it is a specialized intervention that can be used in medical settings, again, with a foundation in motivation interviewing. It has been demonstrated to be effective at facilitating a variety of positive behavior changes. And Brett also explained to you why it's important with adolescents, that fits with their developmental stage. It helps healthcare providers explore these behaviors with a patient in a respectful, non-judgmental frame and within a specific time period. It's quick and can be done quickly. It's designed to elicit reasons for change, and it takes action steps, because sometimes we get people who say, oh, I've done a lot of reflective listening, but then I get stuck in it. This gives you the steps to move forward. It is a step in a script, and that's the other part of it that we find very helpful. Here it is. These are your basic steps, starting with number 1, engagement. These are suggestions, the scripts, the dialogue, the conversation you have, and it helps you to understand what the intent of this is, but also if you're not sure, you can check back into it. And it's also used, and I'll bring this up right now, it's also used as a good tool if you're supervising individuals and they keep coming back to you and telling you, oh, I'm having a problem with this part. So let's go through it. Let's look at it and see, are you hitting these main points? Again, I'm not going to go through every one of them, but when you're engaging with your adolescent, it's, you know, you may have seen them before, so that's a good entree, and so you could lead them from there. If you're just meeting them for the first time, that's also a good entree, so tell me some more about yourself. I'd like to know more about you. I've seen your medical records. I'm looking over your scores here. Just tell me a little bit about yourself. And then, pointedly, you can ask about their drug use and ask them to tell you about how that fits into their life. And ask them also to tell you about what's the most important thing in your life. We hear that there's a lot of athletic physical exams that go on in a lot of the school-based health systems. And so a lot of those athletes, that's a pretty important part of their life, especially if they're looking for those big ticket items into colleges and scholarships. So that's pretty important here. Next thing is to look at the pros and cons. You're now going to start that, what they say, the exploration of the experience that the adolescent is having both with alcohol and drugs in their life and also with those other important points in their life. And using good MI, you're going to talk about what's so good about it and what's not so good about it. We tend not to ask people what's good about it because that would hint that maybe we accept it, but let's ask them. Let them give you that introduction into what's good about it in their life. And the other thing that is also important to remember is what else? You want to elicit those pieces of information from them. That's part of the listening. At any time that you start hearing them talk about good things, you're catching them being good, and they probably don't hear it often, so reflect that back about, oh, those are the good things you've been doing, and what are your thoughts about it? Again, keep eliciting and engaging with the adolescent. Step 3 becomes the part where you now start looking and giving the feedback, which is an important portion of the actual interview. And you're going to be giving information that you've received from them and also from their scores. Again, following good motivational interviewing practice, one of the first things you always do in showing respect for your adolescent patient is to ask for permission. I have some information about low-risk guidelines about drinking. Would you mind if I share them with you now? You've already gotten a background, you understand, and of course, you're getting this because they've scored about 2, so there are risk factors. And then you provide that information. And as I said earlier, they may not know what drinking and binging and what a standard drink is and what it means. They have a bottle they share, they have a roach or another form of marijuana that they share, a hashish, they're using among a group, and they don't always know how much they're getting. But you can help go through it by explaining what that means and what the problems are associated with it. Much of them you've already heard from Brett. And what you do is you help ground them in that individual's life about the risk factors that they've told you and give them that information back so they can make it real in their own world. And again, at the very end of the feedback, you want to know, okay, so what did you think about this? What did you make of this? Can you tell me a little more? Again, doing that elicit, provide, elicit after you've asked permission. Again, MI technique. Readiness to change. Again, this isn't necessarily MI. It comes out of the Prochaska di Clementi. But we're looking at it in the sense of where is that individual now? And where are you going to meet that individual? And that is a pretty handy way of doing it by using the readiness ruler. And the readiness ruler can be used for how ready are you to do this, and where are you in making changes later on, and how do you see yourself now. But you're always going to be looking at it from this scale of 1 to 10, 1 being not ready at all, and 10 being completely ready. And so you say, how ready are you here? Hand them, there are lots of tools out there, hand them this little ruler, and have them point at it. Okay, I'm at a 5. Okay, so that tells me, and there's 2 ways of doing this, that at a 5, that's great. So that means that you're 50% ready to make a change. So, okay, tell me why you're not down at a 1 or a 2. Now, why is that important? Why did I not ask about 6 or 7? At this point, a 5 tells you that they're pretty well far along, but they're still ambivalent. And you're looking at how do I deal with the ambivalence that they've just expressed to me. So when you're looking at this and you want them to envision the change, if you're looking at the lower number and you're saying, oh, so you're at 5, so tell me about why you're not there, and they're going to tell you about the things they've been able to do to improve and or to stay clean, or I don't drink, or I don't drive, I don't ride with my friends. Those are all positive things that you are going to be looking for. Here's the big part, where a lot of people get caught up in the reflecting, and okay, here, this is where you get into the action steps, 4, 5, and 6. And what you're going to be doing is, again, fitting this into how your program wants to look at this. And you start by saying, okay, we've talked about what your use is. We've talked about some of the things you've been doing. So now, is it okay if we sit down and start talking about the ways you think you can help yourself cut down, become completely abstinent, and make yourself a healthier individual. And you can do that quite simply by sitting there and putting down 1, 2, 3, 4 with your student patient in front of you, with the whole idea that they're looking towards their future and where they think they need to be. Exploring the challenges, because sometimes you're going to get to a place where they say, oh, I can't do that. And so you're going to say, well, okay, up to now, we've talked about you not going out with your friends every night of the weekend, maybe just one night of the weekend. And because of your work schedule, that's going to be easier if you do it on this night or that night. Well, do you think that you could maybe, cut back to maybe only twice a month instead of every other week? Those are the types of things that you would have as they draw out. And again, keep going back to those steps that you did on the readiness ruler and find out how they were successful. Build that into your conversation. And also, as it says at the bottom, what are the benefits of the change? And that's the goal that you want them to be looking at, because there's something that has happened, and it's not a quote, that whole thing about trouble, there's been a problem, and if they can talk about that, they can see how there would be a benefit to the change, and they're going to tell you how that's going to happen. The plan, again, is to help them be safe and healthy. Again, you bring that whole thing in, you're there with them. You know if they have any problems such as asthma. You know if there's been an unintended pregnancy or if they've come in for a pregnancy test. So those are the things that you can build into this conversation. And you can help them by building the plan and helping them address each of those issues. So tell me about the time when you overcame past challenges. And that's also the key to, is their family supportive? Do they have a good friend who's supportive? Do they have a teacher who's supportive? Who are those positive people, places, and things that help them get beyond where they are now? And that identifies strengths for them, which they may not even recognize as having a strength. A lot of kids come really down hard on themselves because a lot of adults come down hard on them. So this is a time for them to start looking at that and building on that, and you encourage them. So summary. Summary is absolutely key. I know unforgetful kids tend to float in and out, and if you know there's some time when you might be losing them in the conversation, this is where you put it all together for them. You start out, is it okay for me? I'd like to summarize what we just talked about right now. Is that okay with you? Again, I am going to put this in here. You're always asking for that permission. And you build on exactly what you see. Underneath the summary, you want to reinforce all of the resources. You want to tell them their strengths, show them how they have been successful, and how they can work towards this action plan. Again, if you do have in your school-based health centers pamphlets on alcohol and drugs, on coping mechanisms, on peer pressure, on correct use of sexual contraception, then those are all good things to reinforce depending on what you've talked about. But you review the action plan and you do the ultimate thing, which is you thank the student. You've taken up their time and they appreciate hearing that from you. So where we're going to go next is talking about the referral. Those are some little hints there. But again, I've been talking about it throughout, but the role of the counselor, your nurse practitioner, your doctor, who's ever going to be engaging with a student, is that you have to first gauge where they are. Like as I said, using the ruler, looking at that, looking at their stages of change, and you respond accordingly. And again, good motivational interviewing means you're non-confrontational, because that will shut the student right down and you will get nowhere. And again, I'll talk briefly about motivational interviewing. Here again, we took this from the UCLA match project. Again, it's another version of where the student is, and I like this one in particular because within each of the stages it tells you what your major task is. Some students will come in and they have no idea, and so they're pre-contemplated. They really have no idea that they've done anything wrong or that their use isn't a problem. So you're going to be raising their awareness there. That's where you're going to give the information, you're going to give the advice, and you're going to be pretty, I don't want to use the word blunt, but at least factual and frank about what that use means. When they get to be a little bit more contemplative, then you start going into helping them resolve it. And I would like to remind you that this can all take place fairly quickly if you're using this particular script, if you know your MI. And what we like to tell our people who come for training is that we really want you to have a training background in motivational interviewing, because within our training program, which is about 6.5 hours long, there's no way we can provide you with all of the skills necessary to deliver motivational interviewing in a comprehensive and effective manner. So we encourage all of our practitioners to have that or get that as quickly as possible. So again, you can go around this and look at things of maintenance, which we hope that it will that the student will be able to achieve those goals and to stay at a low-risk level and to make it through their high school and middle school, depending on who you treat, and be able to then develop the better coping skills and management skills to keep them successful. Why do we use this? Because we know it increases effectiveness. Again, we rely heavily on the studies that have been done, and we know that with more brief interventions, multiple ones in our adult study, we call them extended brief interventions, we know that the impact of those interventions will help to reduce risky alcohol consumption, and Brett told you those particular facts at the very beginning. And adolescents who do agree to make that behavior change should be given a follow-up appointment to discuss all of their efforts, praise them, and also keep progress with them, no matter how small it is. Referral to treatment. Numbers will vary among your school's population and who's there. Often people who are in school and coming to school-based health centers do have issues, but we are also aware that many of the individuals who really need to have a referral to treatment are in schools and they're not in our school-based health systems, simply because they're not going there because the problems have gotten so great. But for those individuals who are ranking into a 5+ score on the craft, you should be looking at it, and here we have it from one of our slides. We come up with a referral agreement between one of the OASAS certified programs. In your particular setting, it could be one of your agencies or within your school-based health center, how you have it set up. There will only be a very small percentage who actually need that referral to treatment, but be prepared for this to happen. And while we say this is confidential, and in New York, a parent doesn't have to be present, and a child can be given a referral to treatment without a parent's knowledge, we know that for the best results, you should have your parents involved. They should be involved when there is any high risk of substance use, such as an adolescent who did go to an emergency room and the parent didn't know about it. We recently had broadcasts in the Albany area about the use of opiates, and one mother said, I didn't even know that my child had been in ER. It only happened afterwards that she was aware of it. So again, we recommend highly that you do get parents involved. Your local providers within your network and your systems, it's good to do the education on both sides of the line, both within the school, within your school-based health system, and within the providers in the community, so everyone will understand the procedures that you need to follow. We're going to switch to Gary now, because part of this gets right into how we're going to build for all of these services in the years to come.
Yeah. Just why don't we take a quick break there, because Shirley went through quite a bit of in-depth information there. So just want to see, Chris, do we have any questions there? Have any been identified?
Yes, we do. She was just talking about parental involvement. And I have a question here. Somebody was wondering if there's any kickbacks from parents about the program in the schools.
Kickbacks? Is that?
Yeah, well, do they, are there any barriers? I mean, have you heard any complaints from parents about, questioning their kids?
No, a couple things. One of the things is in New York State there, basically as a part of the agreement the parents have with the school-based health centers, there's certain things that they don't need parental permission from. One of them is talking about reproductive health. Other is alcohol and substances there. So it's a part of you're going to be able to talk with youth about those things without talking with the parents there. But what we've seen in some of the other studies there is actually parents are happy that these issues are actually being brought up and discussed, because obviously, as we know, these things are not the easiest things in the world to discuss with parents and youth there. So I think some of the research we've seen is that parents are actually happy that these topics are being brought up in a healthcare setting. So they're actually, we have, in our experience with individual school-based health centers we've worked with, we haven't got pushback from parents with regards to that.
Oh, that's great. About what percentage of the student population actually passes through a school-based health center in any given school year?
I think it depends upon the school-based health center, because I mean some of the ones we're working with, they have a large number of, say maybe like 70 to 75% of the youth in the school are enrolled in the school-based health center. Some of the other ones are potentially less than that. But I don't have the information in front of me, but I mean the great majority of youth go through the school-based health center who are enrolled over the course of the year. So you're going to hit well over 50%. So again, I don't have the data in front of us here, but you're going to hit a substantial number of youth that are going to be coming to the school-based health center for some reason over the course of the year.
It's usually about 75% that will actually, they're enrolled, will come through the center during the year.
Huh. This next question, it looks like it's exactly what you're going to be talking about here based on the slide that's up. How do school-based health centers pay for the SBIRT program?
Good. Well, we're going to touch on that in about 30 seconds. So
Okay. Well, let me get in 2 more questions then. What seems to be the biggest barrier to getting all school-based health centers introduced to SBIRT?
Well, we're going to talk about some of the barriers in just a couple of minutes there, but I mean,
Okay.
time is, one of the big issues there. Lack of training by some of the staff. Again, actually, Brett's going to go over, some of the survey that she developed there. She'll be able to give some of the specific things there, but time and, lack of, feeling that people are competent in working with this population is, and also, being unaware of the referral sources there. But we'll get into that more specifically in just a couple of minutes.
Okay, and then the last one is somebody was wondering whether all students have a follow-up to see how they're progressing on their action plan.
Well, that's like Shirley just mentioned there. That's one of the things there, because obviously not every youth that comes through there is going to be like, oh, this is interesting, and let me make some changes here. As Shirley mentioned there, level of change there may be, like a 1 or a 2. So in those instances, you're probably not going to necessarily get the youth to come back there. But the nice thing about this is, what we propose is that everyone, when they do come through there, do get screened on the craft there, so you can potentially score some of the, compare the scores earlier to later there. But if there is a willingness for them to make some goals there, that's one of the recommendations we do make there. If they identify some changes they want to make, then we recommend a follow-up visit there as a part of the, recommendation.
And has that been successful? Somebody wants to know if the students do come back to complete the follow-up sessions.
Okay, do
they complete the follow-up sessions in general, and then would they come back if asked for, a follow-up later on to see how they're progressing?
Yeah, I think, and again, it varies. I mean, we don't have the data in front of us here, but I mean, I think that if they're willing to identify some changes there, in many instances, yeah, they are willing to come back in a couple of weeks or a month and report out were they successful on making those changes there. Unfortunately, I don't have the data. We don't necessarily have the data on sort of the recommended return visits and what the actual percentage is there.
Okay.
We are going to get to that a little bit later in the presentation, but we do have some qualitative information from our projects on to answer that, and we'll get to that.
Okay, that's good. I do have one more, but I think it will be better at the end because you might already, plan to go through it now. So you can go on now. Thanks.
Great. Okay. well, we're transitioning here. I'm going to do a quick thing on Medicaid billing and I'm going to hand it off to Brett. One of the nice things in New York State is SBIRT is reimbursable for screening and brief interventions, and it's reimbursable in school-based health settings. So obviously that's one of the benefits and one of the facilitators there of having school-based health centers adopt SBIRT there. So Medicaid fee-for-service will reimburse for 2 screenings and 6 brief intervention sessions per year. Medicaid managed care and FHP plus plans must also allow 2 screenings per year, calendar year, in the allowable reimbursing settings without prior authorization. And plans are responsible for up to 6 brief intervention sessions per calendar year, irrespective of provider, without prior approval. So obviously that's a part of what we're talking about there. The whole screening and brief intervention process should be reimbursable for basic, also the screening and the brief intervention. Here's basically, this is getting down into the weeds there, but this is, the specifics of what providers have to put in their electronic medical record and for billing purposes there. SBIRT may be billed to Medicaid using the following healthcare common procedure codes or HCPCS procedure diagnostic codes. So you have to have a procedure code, and the screening is H0049, used for substance use screening. The diagnostic code is V82.9, unspecified condition, is required on claims for the procedure code, which is 80049. And for the brief intervention, the procedure code is 80050. Brief intervention, the diagnostic code is V65.42. One of the other things that's good in New York State there is Medicaid will pay for screenings, whether they're positive or negative. They'll pay for the screen and then they'll pay for the brief intervention. Private insurance pays for the screen and the brief intervention combined. They don't necessarily separate things out there. So there's better reimbursement resources there for Medicaid students or students that are on Medicaid. And here's just the documentation requirements are required as a part of the OASAS and Department of Health's requirements there for billing purposes. Information on the service provided, is it screening or brief intervention? The score on the screening tool, like we say, we're recommending the craft. Was it 2? Was it 4? Whatever. Problems related to substance use there that either come up from the craft or the further exploration you do. Dependent symptoms, if there are any, and then injection drug use, if reported. So those are the required documentation elements there that have to be in the medical record there for reimbursement purposes. So that's sort of the billing perspective there. And obviously in many instances there, that's an incentive for school-based health centers there to pursue SBIRT, but I mean much more so in speaking with them is the idea to basically provide a good quality prevention service and intervention service for their students there. So the additional revenue is an additional incentive, but the primary purpose is to provide this good intervention service for youth there. So I'm going to hand this off to Brett now, who's going to talk about some of the other sort of barriers and some of the things we try to overcome with our model.
Thanks, Gary. So just to give you a little bit of background on the facilitators and the challenges, there was a well, what we see in the work that we've been doing, and we've done a couple of projects of SBIRT and school-based health centers with OASAS, that providers deliver some of the components of the SBIRT model, but SBIRT is an evidence-based practice for delivering all components of the model in combination. So that includes screening using a standardized tool, so like the CRAFT instrument, delivery of the services based on the screening score sets. That's that protocol that Shirley talked about, the low risk, moderate risk, and high risk. Patient-guided brief intervention using motivational interviewing and that evidence-based process, the brief negotiated interview, or BNI, and referral to treatment when indicated. So actual research was conducted to figure out, in part, what is being done in school-based health centers in New York State. Are they conducting SBIRT, and what parts of the SBIRT model are they doing? So a survey was sent out via SurveyMonkey to school-based health center program directors and the clinicians that serve students that are in middle and or high school. Received 64 responses. It's a 40% response rate. So you could see that the majority, they're 41.8% are doing substance use screening only. And when I say substance use screening, it could be just simply asking them if they use anything, not necessarily using the craft. People that are doing all the portions of SBIRT, screening, brief intervention, and referral to treatment, that's only 21.8%. An additional 9.1% are doing screening and brief intervention only, leaving out the referral to treatment, probably because, as I'll get to later, there are some barriers to referral to treatment. You can see a large proportion don't practice any part of the SBIRT model. Actually, to clarify, the darker substance use screening only would be 14.5%. My school-based health center does not practice any part of the SBIRT model is 41.8%. That's, I'm looking at the screen. The two blue colors look the same. So, attitudes, perceptions, and knowledge were assessed as part of the survey. And 63% don't think that screening will result in early intervention. Almost half, or more than half, don't think that screening will lead to improved student outcomes, and 63% of clinicians only don't think that it is their role to screen students using a standardized tool. Now, just pinpointing that standardized tool piece, there are, people do ask questions whether they're using, and a lot of times rely on their own clinical impressions as to whether a student needs any form of intervention if there's any problem. So you could see that in this study, an adolescent diagnostic interview was used to compare what actual kind of diagnosis a student would have versus what the doctor came up with based on clinical impressions. And those that came up with problem use on the diagnostic interview, only 18 were identified by clinical impressions. For substance abuse and dependence, there's 86, but none of them were identified using clinical impressions. So 24.4% of them were identified as having no use, 50% with minimal use, 15.1% with problem use, and 10.5% with abuse. And as you can see, 36 were identified with dependence, but none of them were identified with dependence through clinical impressions. So that just underscores the benefits of using a standardized tool. So it has that algorithm that tells you what services to provide. It takes the guessing game out. And using a standardized screening tool results in higher detection of problem substance use and is a best practice. Use of informal screening, or using a larger health assessment, which we know in school-based health centers, such as the GAPS or the RAPS, are being used. These do not provide these features. So another issue is perception of intervention effectiveness. So among the New York State school-based health center clinicians, many of them, between 70 and 78%, do not feel effective at helping students reduce their substance use based on what they're currently doing. However, only 25% don't feel effective at helping students prevent unwanted pregnancies or contraction of STDs. And the reason I bring this up is because they're both sensitive topics that are sometimes difficult to talk about. However, there is a big discrepancy here based on effectiveness at addressing these issues. So current practice of the SBIRT model. So I'm going to focus on the rightmost column, the practices that are the percentage of these being practiced more than half the time. Because remember, SBIRT is supposed to be done routinely, universally, all the time. So really these practices should be done more than half the time. And you can see these are the pieces, the components of the model listed on the left. And some of these practices are done less often than others. So one of them is formally screening students for risky substance use using a standardized tool. Just more than half of them are actually doing that, using it more than half the time. Another one is referring students to treatment that likely have a problem. Another one, which Shirley talked about, assessing students' readiness to change their risky substance use. This is a unique component of the model, and that's not done as often as it should be. And once again, I'm just going to bring up providing positive feedback and encouragement to those not using, explaining the effects of substance use to students. So when you provide that feedback, you can actually letting students know what effect it's having on them. So this means that there are some substance use services being provided, but not in combination, following the evidence-based model. And that really, as I mentioned before, they don't feel effective at addressing substance use using current practice. Providing standardized SBIRT protocol may make them more effective at helping students reduce their use. So now I know the barriers, that was a question that was brought up already, so I'm going to go over barriers that were raised in the survey, and then we can also talk about barriers that were brought up in focus groups of our pilot project, and then technical assistance calls that we've had in some of our projects in SBIRT in school-based health centers. So barriers to actually discussing substance use was, the biggest one was time constraints and students not being truthful about their use. Another one was lack of training and not knowing where to refer students for treatment, and uncertainty regarding effectiveness of the service. So once again, that points to that perceived effectiveness of addressing substance use. We did find time constraints being an issue when we talked to the school-based health centers. However, they did say that it standardized the service they were already providing, so it really didn't, in the end, when we talked to them after the project, add any additional time to what they were doing. It just made it easier for them. They did say that students were, in fact, truthful about their use because they kept repeating that this is confidential, and they gained the trust of the students. So, and then you also mentioned follow-up. So these are the follow-up brief interventions. And in our pilot project, it was raised that there were barriers to follow-up, and these are actually, those barriers were consistent with what was found on the survey, students not thinking their use is problematic. So whereas SBIRT is great for identifying those students when they're coming in for another health issue, and then they can get a brief intervention during that appointment, when they're asked to come back just for that brief intervention to talk about their substance use, if they don't think it's problematic, they may not come back with the task that's given to them to draw them to the school-based health center. Another one is that students who use are often absent from school, and one of the school-based health centers that we worked with really wanted to address the issues from these students, and they said that some of them are they're often absent, and they also drop out of school, and they were trying to figure out how to reach these students. And then, surprisingly, teachers getting annoyed when students are being pulled out of class. So trying to find out, the best times to bring them into the school-based health center, such as during a lunch period or free periods. And for referral to treatment, a lot of times students are not interested in treatment. Another thing is that there's a lack of adolescent-specific treatment programs in the area. Unfamiliarity with any treatment programs in the area, and then that there are social workers on staff. So all school-based health centers are required to provide mental health services, whether on-site or just with a contract with an outside provider. And the ones that we worked with did have social workers on staff, and a lot of the referrals to treatment are provided, they're actually sent, the referrals to internally to their own social workers. Some other challenges, a lack of training in substance use topics. So I'm not just talking about SBIRT, but I'm talking about if you're going to provide feedback, then you need to know what the problems are and how substance use does affect students. And then there's differences based on geography. So in New York City versus the rest of the state. So targeting school-based health centers in different parts of the state requires tailored efforts. So just as a small example here, the training found on this survey showed that in New York City versus the rest of the state, and then for clinicians and program directors, that the clinicians in New York City had the least amount of training on substance use screening, on explaining the effects of substance use on students, and advising students to change their risky substance use. But across the board, the clinicians, the ones who are providing the services, have need more training on these background topics. So as I mentioned, OASAS has experienced pilot at SBIRT upstate and downstate. And in 2012, there was a pilot of 5 total school-based health centers with 2 organizations, Morris Heights Health Center in the Bronx and Winthrop University in Long Island, and also Rochester General Hospital, University of Rochester, and Bassett Health System currently for a total of 6 school-based health centers. So downstate, 400 students were screened over 3 months, and 35% had used substances. The students and staff were satisfied with the service, and as I said, the staff felt that SBIRT standardized the delivery of substance use services in their school-based health centers. Now I'm going to turn it over to Gary, and he can discuss the upstate pilot and then some ways to support the provision of SBIRT in school-based health centers.
Thanks, Brett. Here's the information for the upstate pilot. Is 200, and this is the data forms that we've received. We expect probably there's more students screened, but this is the data that the school-based health center sent us. 263 students screened over 5 months, 14% reported using substances, 10% scored greater than 2 on the craft there, and there's 23 brief interventions delivered there. One of the things we discovered about this is the percentages are sort of lower than what we would sort of anticipate, because as Brett mentioned there at the beginning of the presentation, over 38% of youth between 9 and 12 grades report using the last 30 days there, but obviously, only 14% reported use in our pilot there. So that's one of the things we're going to be doing at the end of this, or in June there, we're going to be going out and doing focus groups with the school-based health centers and asking about some of these more clarifying, detailed questions there. So staff and students are accepting of SBIRT. Reported successes are increases referrals to their own collated social workers who provide the mental health services there. They have an opportunity to bill and are being paid. There's a greater identification of risk use used by the students there. Again, using the craft there, you're going to identify more youth that way. Not time consuming. I mean, one of the things about SBIRT is, what we believe, and I think for it to be effective and to be maintained, is you have to integrate it into your own existing system. The nice thing about SBIRT is there's a lot of flexibility in how you can do it there, but obviously you want to integrate it in a manner that is the least labor intensive and resource intensive as possible there. And the challenges are payment and adding billing codes to the electronic medical record there. Payment's not always consistent across the board there, and we have to, along with the school-based health center, sort of explore why some of those bills are not getting paid. So, supports. We've heard some of the barriers there and some of the dilemmas there. And one of the things about this is, there's a decent amount of literature out there about implementing evidence-based practices. Because like we said there, SBIRT is an evidence-based practice there. So as opposed to reinventing the wheel, there's good literature out there about implementation of evidence-based practices there. So this is where this basically comes from. And we'll go into these a little bit more in depth each one. Facilitate a supportive administration. Identification of a champion and implementation team, use of purveyor groups, which we'd like to consider ourselves. That's what we tried to do as a part of OASAS, providing the ongoing training and support to the school-based health centers, training, coaching, and consultation, evaluation of staff performance and feedback, supportive data systems, just the quality improvement of Plan, Do, Check, Act or Plan, Do, Study, Act cycle, and importance of linking school-based health centers to the AOD treatment providers. Supports for successful implementation. I hate to say it, but it's more complicated than you think. It's you basically have to have a plan for this, and you have to basically allocate resources there, because as Brett mentioned there, people are doing a lot of these things, but not necessarily in this sequence there, and not necessarily tracking about how they're implementing this. So, first thing is you need to facilitate a supportive administration. They need to make sure the practitioners have the time required and the skills needed to be able to deliver the service. You need to develop a data system to support evaluation and performance improvement needs. Don't count on just subjective opinions on, well, this seems to be working. Really critical is identification of a champion and implementation team. We've seen, and again, this isn't just SBIRT projects, but any evidence-based practice there that you want to implement with fidelity is almost always implemented by a team, not just some individuals there where there's planning going on there. And what they have to do is help define the implementation strategy. There's several questions you have to have answered about, when you want to implement SBIRT. Decide on the screening instrument. Define roles of the staff, who's going to be providing the brief interventions, where are they going to be providing that. Design how to integrate SBIRT into the existing system. What you do not want to have is this as an add-on to everything else they're doing. You want to integrate this into the system that already exists. Identification, and again, there's good research on implementation of new, new projects within healthcare, and about the importance of champions there. And what the literature demonstrates, there's two types of champions. Project champions that are sort of, they own the project there, that it's their responsibility for successfully implementing, in this instance, SBIRT. There's organizational change champions that work with a larger organization to make sure that this aligns with the overall goals that the organization has, and also provides the resources that are necessary. And I hate to say it, but without champions, far less chance of successful implementation. Here's a little grid, and again, this comes from one of the resources there, the project champion and the organizational change champions, what sort of their roles and responsibilities are. And you can read these as well as I can. But I mean, the project champion is his or her responsibility for owning and doing what's necessary to move this project, in SBIRT in this instance, to make it successful. The organizational change champions, and most likely at a higher level, working with the organization to make sure this aligns with the overall goals of the organization, and also that the resources are available. Use of purveyor groups. That's what we try to do here at OASAS, is provide the training, the ongoing monthly support through conference calls there, trying to iron out any glitches or problems that go on there. So these groups have special expertise in the evidence-based practice. That's what EBP stands for. In this instance, SBIRT, providing the training, ongoing consultation. Also having expertise in implementing the innovation successfully. So I mean, that's, I think, what we've developed over time is in the pilot and the demonstration projects there. Unfortunately, most evidence-based innovations do not have an established purveyor group. If you do have one, you have a higher probability of success. Training. I mean, training is sort of a given. You have to provide the training to the direct service providers, so they need to learn to use when the new approaches, and they need to be able to learn the new skills and practice the new skills. Training in of itself provides background information, theory, philosophy behind these things. Opportunity, like we do, we have some practice exercises there as a part of our training there. But again, as Shirley mentioned there, you really can't learn motivational interviewing skills or the skills through SBIRT in just a one-shot deal there. So you're going to have to pick that up either through ongoing coaching or within the program or outside trainings. Training. However, classroom training by it and of itself is not sufficient to ensure training staff will develop the capacity and effectively implement the innovation. Most skills needed by effective practitioners can be introduced in training, but must be practiced and mastered on the job with help of a coach or coaching. Coaching is basically providing ongoing consultation at the site, ongoing feedback on basically the responses to the interventions there, someone to bounce stuff off of, someone to get their questions answered there. Unfortunately, only 10% of what is taught in training is actually transferred to the job. When on the job coaching was added to training, large gains were seen in both knowledge and skills. Most important, about 90%, and this was done with teachers in a school setting, 90% of teachers used the new skills in the classroom with the students when there was coaching added. So it's a given. The school-based health centers need to develop the internal expertise to connect in a coaching role and use data to help guide you. Evaluation of staff performance and feedback, providing supervision, ongoing motivational interviewing training, some way of review of sessions, audio tapes, provide fidelity checklists. Highlight that. Go to our resource list there. There's two good, well, there's hopefully a lot of good stuff, we think. But I mean, 30 and 31 are basically scoring sheets and a fidelity checklist, more or less, for delivering brief interventions. So make sure you go there, print that out. Again, we got that from BNI there. And need to build feedback in some way there. Supportive data systems. One of the first things is, ask the school-based health center, what data do they need and want to be able to determine whether this intervention is successful. Try to integrate as much as possible the data collection into the electronic medical record, because you're going to have to do that anyway. So the more you can put that in there and not keep like two systems, it'll make your staff and less crazy. Outcome data is difficult to collect. I mean, if you can, what you're basically looking at changing behavior of students there. You're looking at changing an AOD use or decreasing consequences. Again, that's a little bit more labor intensive. But what you want to look at is process data is easier to collect, and what you want to collect here. What you want to look at is, what percentages. Brett mentioned there, you'd like to have this be universal screening. So you'd want to look at, okay, what percentage of possible youth get screened? Of the ones that you want to find, you always want to know what percent screen positive. Of the ones who screen positive, again, you would like all of them to get brief interventions, but again, that may not always be possible. You want to know what percentage received the brief intervention, what percentage returned for the second visit if it was suggested, what percentage were referred to treatment, what percentage that got actually to the referral source, and a percentage that accepted into treatment, and last but not least, if there's some way of gathering participant satisfaction. We developed participant satisfaction surveys for the students there. We're collecting some initial data on that, but obviously you want to collect their perspective on this intervention. Unfortunately, having to go quick here, but we'll get done in just about a minute. Any healthcare setting, obviously you need a Plan, Do, Study Act or Plan, Do, Check Act, because things are going to need to be modified. We've made changes here in the way we do this project, so we try to do this on our level also. Make sure you're making decisions based on data, not just on subjective beliefs. Include frontline staff in decisions and implementation, because they're on the front lines and they're doing it. And make sure you link the school-based health center to the AOD treatment provider. Many times, growing up, you got health care in one setting, you've got addiction treatment someplace else. A lot of times they don't know about each other. They don't talk with each other. So as a part of this, make sure you have a sit-down meeting where they can introduce each other, schedule meetings with the school-based health centers and the treatment providers. Make sure they understand what the referral requirements are. See if you can expedite that in some way there, because if you want to make a referral into a treatment program and the youth has to wait a month to get in there, he or she may not be that terribly inclined to go there. And identify a contact person at the AOD program for questions and consultation. Out in Rochester there's a meeting that basically the school-based health center set up with one of the treatment providers there to develop an ongoing relationship, and also to figure out how to make referrals into the treatment system there, because obviously they're finding youth that they believe should go into treatment there, but as of right now they're not willing to participate there. So they've taken it upon themselves to set up that meeting to hopefully facilitate some of those referrals, and also figuring out how to motivate the youth to accept the referral there. So that's pretty much it. I know we threw an awful lot of information at you in about, actually a little bit too long. Hopefully there's folks still on there, and I'll hand that back to you, Chris.
Yes, everybody is still here. And I do have a couple questions if you wouldn't mind staying on a little bit longer to answer them.
No, sure.
Okay. Do the payers that combine screening and brief intervention pay if the screen is 0 and the BI is saying keep up the good work?
No, they the other payers there, which would be basically private insurance and Medicare, no, they wouldn't pay for important part. What we believe is obviously providing the positive reinforcement, though. But no, they would have to be a positive screen to be able to deliver the brief intervention and be reimbursed.
Okay. And do you see that any students are reporting use of synthetic marijuana or heroin or perhaps sniffing?
Again, we probably, we don't have the specific numbers on that there, but it's certainly in New York State, and I think all around the country, there's certainly heroin in the prescription opioids are pretty high. The synthetics with marijuana, I think we've lessened that somewhat in New York State, because we basically, banned the sale of those in supermarkets and in other places where it's available there. So the number one drug that's reported is marijuana. Mm-hmm. Marijuana's first, alcohol second, and then sort of it trails off dramatically. But the number one drug of use that's reported in school-based health centers in the SBIRT is marijuana.
Do you think SBIRT can be successfully utilized in schools without a school-based health center, but with a school-based nurse who is either full-time or only at the school specific days of the week?
Well, I think we're, SBIRT is basically, you're doing a screening and you're doing a brief intervention. It could probably be done by a nurse in a school there. The challenge is, at least in New York State, it wouldn't be reimbursable. Reimbursable for SBIRT. May be reimbursable through, however, the school gets, paid for specific services there. But again, when you look at screening and brief intervention, we sort of believe it. Anytime you have a large number of people coming through some type of service, if you can do a screen on them, and if you can teach the individuals how to do the brief intervention, it could be effective. Obviously, it's a different model than what we're talking about, and there's also the challenges of within the schools, there are the confidentiality issues that don't exist within the school-based health center.
Yeah. And we're also, we're exploring, there probably would have to be a different model to get the students the services they needed doing it in schools. But it is possible, but there are some more challenges.
Here's another one. I noticed that you regularly describe counseling staff as social workers or clinical practitioners. Can other categories of staff also provide screening and follow-up?
Yeah. What we found in school-based health centers tend to have physicians, assistants, nurse practitioners, and social workers tend to be the majority of the professional licensed staff there. So basically, any of them can provide the brief interventions.
Yeah, in our pilot project, especially in Morris Heights, they had health educators on staff who provided the brief intervention. So that's also another type of staff person that can do that.
Okay. Let's see. Are there alternate evidence-based interventions for adolescents? And if schools have guidance counselors, social workers, how is there overlap or collaboration between staff and the SBIRT providers? So the first part is alternate evidence-based interventions for adolescents.
Yeah, it's not an SBIRT model. New York State has, this is sort of what we do in schools. It's a brief intervention model called Teen Intervene. It's not, it's similar to SBIRT in about 80% of the, 80% of the same ways there. Teen Intervene has a longer, you're looking to do 2 to 6 sessions with youth there. They're longer periods of time, between 30 and 45 minutes, which many times you may not have in a school-based health center. And they provide a little bit more like some of the skills for like refusal skills and problem-solving skills, and looking at the development of other resources to support your making changes there. So that is that's another evidence-based practice. It's similar to SBIRT in many ways, but it's more of a brief intervention model that's a little bit longer. And what was the second part of the question?
It was if a school has guidance counselors and social workers, how do you handle the overlap if they're all doing SBIRT?
Well, that's one. I think that's one thing we could, look forward to in the future. In working with the school-based health centers we have, we basically work primarily with the school-based health centers. Obviously, they exist within a school, so down the line, it might be something we look at as trying to integrate, or getting basically the school-based health center and the school on board there, because obviously nothing that happens in the school-based health center is going to be detrimental to the school there. So it's something we haven't done as a part of this project, but it's probably, for integration of all of what we're talking about, it's probably not a bad idea.
Okay. Is there any difference in outcomes for students that experience an individualized intervention like SBIRT compared to a group-level intervention like DARE?
We don't have outcome data specific for our projects, but in the research, now I did present the research on SBIRT earlier in the presentation. That is an evidence-based intervention. And the DARE program, the research shows it lacks, it does not say that it's effective. There's no evidence that the DARE intervention is effective. So yes, SBIRT is effective when you compare it to the DARE intervention, and they also work on for different populations. DARE is for elementary school students, and it's focusing on prevention, and SBIRT, while also having a prevention piece, focuses on early intervention as well. It actually catches students along the spectrum, so even for dependent students, to identify them and to try to get them into treatment.
Okay. And here's your last question. If health educators provide the screening and intervention, can they, sorry, just a minute, can they bill?
Yeah, I mean, it's a little, they need to have additional training, because in New York State they need to have 12 hours of training, but yes, they can bill for the SBIRT services along with, the nurse practitioners or the social workers or whomever there.
Who are required to have 4 hours.
Okay. Okay, well, thank you. I had one last question, but it's for me. Tomorrow morning, everybody will get an email from me with the links to this recorded webinar, the links to the slides, a certificate of attendance, and a link to the order form where you can order either the NADAC or Pennsylvania CEUs. So all that will come from me tomorrow morning in an email, so look for that. And with that, I think we will close this session. I really appreciate everybody joining, and I appreciate the presenters for staying late to answer all these questions that have come in. So thank you all very much, and please sign up for future webinars.
Thank you.
Thank you.
Goodbye.
Bye, everybody.